All right. Hello, everybody. This is Jason Scott from Intermountain Healthcare. Thanks for joining the webinar today. So this is our first webinar as the regrouped safety program as part of the High Value Healthcare Collaborative, a continuation of the hospital engagement network that had been going on for a couple of years. So we've added a few new focus areas based on the interest and work of the collaborative, Iatrogenic Delirium being one of them. So we're kicking off our training webinars for the new areas with this, led by our subject matter expert, Dr. Andrew Massica from Baylor Scott and White Health. So it sounds like we had a good sort of brief introduction on the group. It looks like the group is big enough that we'll maybe hold off on introductions, and then at the end of the presentation, when there's time for Q&As, if there's any questions or comments that come up, we'll do introductions at that point. So with that, I'm going to go ahead and turn it over to Dr. Andrew Massica to present the work on delirium.
Okay, great. Jason, thank you. Before I get started, just if anyone has a question that needs clarification during the talk, do you have the raise hand function turned on, and you can just relay that to me?
And sorry for interrupting. And as also just a note and a reminder, all the lines are active. So if you're not talking, please put your phone on mute. But if you do have a question, you can either raise your hand and we'll stop and take the question, or just go ahead and speak up as well. Thanks.
Okay. Well, thank you, Jason, and thank you for giving me the privilege to talk to the group. So as Jason mentioned, the sort of the overarching topic in one of the new areas for the safety work within the HVAC and the larger HEN is iatrogenic delirium. Specifically, what I'm going to be talking about today is use of a coordinated set of care processes known as the ABCDE Bundle. And my business case for doing this is that it's going to be good for your patients, and we really see this just as sort of a driver of quality of care. But then more germane to this group, it's emerging as a patient safety intervention. Next slide, please. So this gives you some background on Baylor Scott and White Health. In October of 2013, Legacy Baylor Healthcare System merged with Legacy Scott and White Health to form the organization that you see on the slide. We have 43 acute care hospitals, and as you can see in the rest of the bullet points, a lot of clinical volume. And so we view ourselves as, when you talk about clinical effectiveness and what works in the real world, we bill ourselves as being a real-world site that seems to work pretty well in grant applications, et cetera. But that also creates some challenges just in terms of coordinating efforts at an enterprise level. Most of our physicians operate, at least in North Texas, operate in a fee-for-service mechanism. So, again, trying to find different ways to make those physicians accountable and change behavior. We'll talk more about that. But again, we really pitch ourselves as a large, real-world clinical care delivery system. Next slide, please. Okay, so taking a look, and specifically this talk is going to be focusing on ICU delirium. So if you look at groups of patients that have ever had an episode of delirium during their ICU stay versus those who never had an episode, it is associated with a whole host of bad outcomes. Increases in ICU length of stay and hospital stay, nearly double the time on the ventilator, higher costs of care connected to those, higher mortality, both within the ICU and overall within the hospital stay. And increasingly, we are also starting to see building evidence that an episode of delirium is a risk factor for long-term cognitive impairment. So the typical scenario there is you have an elderly patient that is in sort of a slow decline, and you have an episode of delirium that's like falling off a cliff. This can be very consequential in terms of people's ability to either live at home or require an assisted living type of environment or a nursing home. And this is it's sort of most prominent in the elderly patients, But there are lots of examples of even young patients in their 40s and 50s without many comorbidities having an episode of delirium, but just never quite get back to where they were before the illness. So building evidence base for that. Next slide. So as we move towards a more patient-centered care system, I think this is another important concept to associate with ICU delirium. If you talk with patients that have had an episode of critical illness, they often describe something that's very similar to a PTSD-type syndrome. From a patient satisfaction standpoint, both from the individual patient and from the family members, it's obviously very disconcerting to have a loved one hallucinating, grabbing at things that aren't there. And so just in terms of one more sort of piece of the business case that you would need to add, that this should be a priority area for your system, the patient experience of PTSD and wanting to avoid that is another good one. Next slide, please. So ICU delirium used to be put in the category as sort of an unavoidable consequence of critical illness. And so if you think back to 15 years ago, probably 20 years ago, where sort of the same concept was applied to central line infections and venous thromboembolism, that those are things that just happen in very sick patients. Delirium in the intensive care unit was sort of fit into that category. However, like those other conditions, it is clear that delirium, there are risk factors for delirium that can be addressed to lessen its frequency. And then when it does occur, there are things that can do to mitigate the condition. So that's what makes it sort of particularly appropriate for a patient safety initiative, is that not only is it a recognizable problem, but there are specific care processes that can counter it. Next slide, please. So what you have here is the set of care processes that I referred to as the ABCDE Bundle. Now, a side note, there is a group that we have worked with very closely at Vanderbilt, the ICU Delirium Study Group. They actually have modified, they and other groups have modified what the different letters stand for, and they've also included an F. So they use something called the ABCDE Bundle, and F stands for family engagement. What we'll be speaking to are sort of the core concepts here of the ABCDE Bundle, but just know that there are slight variations on this theme in terms of what the acronym stands for. So A stands for awakening, so patients that are on sedation, turn the sedation off, let them wake up. B is the spontaneous breathing trial, so allow patients to assess whether or not their ability to breathe on their own. It really should be ABC squared. There's two C's. So C is coordination. Applying this bundle in an actual clinical care delivery setting requires good teamwork. As you can imagine, you can't do a breathing trial if the nursing staff hasn't turned off the sedation. Likewise, you can't do physical therapy if you don't have the timing right and a patient is down in radiology when physical therapy comes by. So coordination is one of the key C's. The other important C is choice of sedatives and analgesics. So there is a good evidence base that certain types of sedatives and analgesics are deliriogenic. Opioids and benzodiazepines fit into that category. And so there's a shift moving towards how those medications are dosed, moving from continuous drips to bolus and PRN dosing. And then likewise, using other medications, propofol, and then the new one that just became generic, dexmedetomidine, is increasingly being used. So those have typically been, and in several studies have been associated with better outcomes. The D stands for daily delirium monitoring and management, and then the E is early exercise and mobility. And so the overall principle here is that when you have a critically ill patient, wake them up, get them off the ventilator, get them moving, get them out of the ICU. That is the way that you're going to reduce the risk of complications and improve their chances of good functional status in addition to survival through discharge. Next slide, please. So I think one of the concepts that applies here. I think it applies in a lot of safety work. It's something that a colleague of mine on this project, Greg Maynard, he developed this when he was at UC San Diego. He's actually the new Chief Quality Officer at UC Davis now. But he came up with this concept of the hierarchy of reliability. So when you're talking about patient safety, you want care processes that are delivered 100% of the time to those patients who need them. So if you look at the first level, what we call the state of nature, where you just tell clinicians, do this because it's best practice, because it's the right thing to do, they'll get it right about 40 to 50% of the time. As you move through the next levels, you have protocols. Those would be things like order sets, decision support, other things that would sort of be associated with higher uptake of the practice. Those types of things, you can get into the 80 to 90% range. If you really want something delivered reliably all the time, sort of the state that you need to get to is something that we call measurvention. So the concept of measurvention is that you can recognize a process gap and address it in real time while it still matters to the patient who's there. So seeing a report, this is like when I get my core measures reports, 6 months later, if I missed a vaccine on someone, that doesn't really help. I feel bad about it, but that doesn't really help the patient while they were still in the hospital. So I think a similar concept would apply to deep venous thrombosis prophylaxis and then glycemic control, or two other areas where this notion of measurvention really comes into play. Next slide, please. Next slide, please. Okay. So what we have here is the set of tactics that we deployed within our system to help drive adoption of the ABCDE Bundle. And just at a high level, looking at this table, these are things that are going to be pretty standard for most safety and quality improvement efforts. So activation of physicians and nursing champions. One point that I'll make here is that these particular care processes are very much driven by the nursing staff. So in terms of the groups that you really need to engage and get buy-in from, I would say that they are equally or maybe even more important than the physicians here. Assessing the current state, the rows that you see in yellow, those have to do with leveraging the electronic health record. And we'll get into more detail on that in a second, in a few minutes, I should say. But that was really one of the keystones getting this project up and running, was getting the IT and the electronic health record right so that this care could be delivered, documented, and then reported upon using the electronic health record. And then the last piece of that would be the training. What we learned with our experience here was that to really be efficient with this, this is an area you probably want to hold the training until the EHR documentation and the decision support tools are ready. Otherwise, you'll end up doing multiple training sessions. Again, we'll get more into that. And then the last one, which was very important, particularly in a fee-for-service system, is accountability. So we do have some clinical leadership who have dollars at risk according to performance of the ABCDE Bundle. And that tends to be a big motivator. Next slide, please. I can't emphasize this enough that adoption of the ABCDE Bundle is a team sport. So on the left-hand side of the slide, you see sort of the array of stakeholders from C-suite leadership down to multiple disciplines, nursing, physicians, therapy service lines, pharmacy, IT. Everyone really has to be on board for this type of thing to work. And on the right-hand side, you just really see that, in this particular process, it's important that it is interdisciplinary rather than multidisciplinary. Multidisciplinary, if you just have different specialties sitting around the table, that's good. But what you really need to do to make this work is to have them sort of function as a coordinated team. Next slide, please. Okay, so now some specific revisions that we made in our electronic health record. And a common theme here is that we used our electronic health record to derive performance reports on the bundle. One's ability to do that, and this is going to be true for any EHR, directly correlates to the quality of the structured documentation on the front end. So if we look at the first care process, the daily awakening trials, what you see in the red box is you see the structure, and this was embedded into a critical care flow sheet. So critical care flow sheets, we use the Allscripts electronic health record system. So flow sheets are really where the nursing staff spend much of their time doing the documentation. So we embedded a structured note surrounding the sedation vacation trial into that workflow as a field. So if the specific questions were, and these were all associated with pull-down windows, did the patient receive a sedation vacation today? If not, why not? And then there are well-defined safety criteria about why a patient would not be able to receive a sedation vacation, and then you'd have your answer. Again, you can see the advantage of this is it allows you to pull out a lot of information on the back end in terms of the performance of that specific process. Next slide, please. So in our system, in the critical care environment, for the most part, it is respiratory therapy who's doing the breathing trials. This is an example of their structured note. What you can see in the top box as well, so if you look at the first question, did the patient receive a breathing trial today, yes or no? If you move down to the next box, then that really has the exclusion criteria. And the things you're looking for are ones that would typically make sense. So hemodynamic instability, they had a high oxygen requirement, they may have had an impending procedure, radiology or surgical procedure, so that trying to wean them off the vent would be inappropriate. But again, using the structured type of format, what it allows you to do, it allows you to document what's going on with the patients and why they're not eligible for the trial. But then when you're doing your calculations, you can pull these people right out of the denominator, so you can exclude those who weren't eligible for a given process at a given time point. And then the next box down, it just shows you the different reasons why the patient may have had their breathing trial discontinued. Next slide, please. So two things to think about in terms of delirium assessment. So we use a standardized sedation scale called the Richmond Agitation Sedation Scale. So one thing worth mentioning is that Baylor Healthcare System, Mike Ramsey is an anesthesiology there, very involved in critical care, Society of Critical Care Medicine. He's actually done a lot of work in sedation scales. There was actually a scale in use called the Ramsey scale. So there was a concern within our own organization. Well, could we really convert from the Ramsey scale to the Richmond Agitation Sedation Scale? Well, Dr. Ramsey is a terrific guy, and everyone agreed that the Richmond Agitation Sedation Scale was more intuitive. It's also been validated, and so you can see that on the left. So there's two steps to assessing delirium. One is you have to assess the patients of awakeness. So patients who are at the low end of the sedation scale, and that's at the bottom of the page, the -4, -5, deeply sedated, those patients who are not arousable, that's what we define as coma. Then you move over to if the patient has a RASS of -3 or above, then you can move to assessing delirium, and that is with the tool called the CAM-ICU. That stands for a Confusion Assessment Method. And this particular tool is adapted for use in the ICU. There is a confusion assessment method that can be performed on floor patients. That's actually who was originally developed for. The ICU modification accounts for the fact that many of those patients are going to be intubated and can't speak. So you can assess their cognitive status and their thinking through hand squeezes. And even there are modifications you can do it with eye blinking. So you go through that, assess the sedation, then a formal delirium assessment with the CAM-ICU. And there's a lot of information available on the CAM-ICU on the Vanderbilt website, and then other sources in the literature. Next slide, please. Okay, so this is just where we have embedded the confusion assessment method. Again, this is within the critical care flow sheet, and these are all structured fields with pull-down windows. So we really view this as a form of decision support as well. If you were to hover over certain windows, those two images that were on the previous slide actually show up as a reference for the nursing staff. And in terms of defining whether or not a patient has delirium, So any patient with a positive CAM ICU assessment is considered to be delirium. So if you have that on any given day, that's a day with delirium. So just keep that in mind as we talk about outcomes. Next slide, please. And then the last piece that we have related to the nursing documentation has to do with exercise and mobility. And again, this is just a structured field. We found when we did an assessment with our nurses that depending on when and where you trained, there was a big gap in terms of who felt ownership of the exercise and mobility piece. Our nursing staff that had worked in surgical critical care ICUs or had been trained and anything more than about 15 years ago, they were really comfortable with mobility and felt that they owned it, and that was something they just felt they did. Some of the more recent graduates, or those who had been in different environments, they had gotten used to just consulting PT for all mobility. And when we looked into this a bit further, it's a numbers game. The physical therapy market is very short-staffed, just in terms of the number of people trained versus the job openings. I think within our own organization, we had 10 to 15 job openings that even with competitive pay rates, they can't be filled. So what that told us was that there were not enough physical therapy staff to have ownership of all mobility, and we really needed to have the nursing staff take the first line ownership of that. And then for those patients that failed to progress, those patients that needed assistance, that was really the group to get physical therapy involved with. I would say that is a big cultural change. Is the concept of having an intubated patient walking down the hallway is sort of revolutionary in some units. So that's, quite candidly, we're still on a journey with that particular component of the bundle. But we're really starting to see the nurses take ownership of that. And just as a general note, if you think about the whole process, implementing this bundle, it really allowed our nursing staff to feel like they were practicing to the top of their license. These were things that they knew needed to get done, that they knew would benefit their patients, but they were often frustrated waiting for a doctor's orders. So the fact that we just sort of hardwired this in as a protocol was very empowering to them with some of the feedback we got. Next slide, please. Okay. And so what I talked about all the different structured documentation for the flow sheet. That is our particular EHR allows summary viewers, and we feel that the summary viewers are really useful just as a rounding tool for physicians, for a unit manager, something that could give you a snapshot of what was going on with the patient, and then if something needed to be addressed, it can be done in a timely fashion. And so we rolled all of this, the particular components of the flow sheet into something that we call the viewer. And this is just an example of how this appears in our screen. So again, the people that find this most useful, physicians during rounds, unit managers doing spot checks on patients, et cetera. Next slide, please. Okay, so before I get to the frontline, the training piece, the other thing I will note, and this was important when we talked about physician rounding and use of the viewers and how the bundle was empowering to nursing staff. Historically, when we just had sort of the state of nature approach, it was an opt-in, so physicians had to actually check a box to activate the particular orders in the protocol. We knew that to really get to really hardwire this and get reliable adoption, we had to shift it to an opt-out process. So all those things that we just talked about, the actual order that allows the nurse to do the assessment for these care processes, that is all triggered. So if a patient is on a ventilator, we have pre-checked boxes that allow activation of the protocol. And that subtle change was really important in terms of eliminating the barrier. They no longer had to wait for physicians. Sometimes particularly if the pulmonologist has an outpatient practice, it could be 3 or 4 in the afternoon before the rounding starts. And it's obviously very hard to wean a patient off sedation, do a breathing trial, and get everything in. Typically, you don't want to be trying to take people off the vent on night shifts. So, again, moving to an opt-out versus physician opt-in system was also very important. Okay, so training. We had two components of training. One was for sort of our frontline staff. We did initially. We had a workshop for the interdisciplinary team, nurses, respiratory therapists, and physical therapists. What we felt, and as a result of that, we felt that most of the staff need to be able to identify the components of the ABCDE Bundle, describe strategies for implementation, identify what some of the barriers would be and how they would surmount those barriers, and then we really wanted them to be able to understand the changes in the electronic health record and then how that would impact their workflow. Next slide. And ultimately, we boiled that down. We boiled that frontline training down to about 90 minutes. You can imagine trying to train a whole ICU staff between day shifts, night shifts, weekend days, weekend nights. You have to reach out to a lot of people. So that frontline training was really condensed down to about 90 minutes to 2 hours total for those groups. And again, using things like adult learning theory. What was also important was making them demonstrate their ability to use the bundle rather than just didactics. So the other thing within a large system is that we needed to make this sustainable and have an enduring resource. So we also created super trainer courses that would allow us to scale this up at the individual sites. So this was a more extended training session. And so ultimately, the idea is that these people would be based at the individual hospital facilities and be able to train their peers related to delirium. Other important pieces were becoming very comfortable with use of the new electronic documentation. We did have a video that had a patient. It was actually it had a colleague that had been in the ICU and had experienced the PTSD and some of the other things I talked about. That was very powerful when people commented on it. Hands-on training with teach back was another important strategy. And then we also created some e-learning modules on our system portal that they could access. And those are going to be usable in terms of the onboarding process for new staff, anyone that may be hired in the mid-year cycle, et cetera. Next slide, please. And then lastly, I talked about accountability. So at the top, just references a specific goal that we looked at. Now, the specific patient group that we applied this to, when we looked at our whole panel of critical care patients, about half of them were on the ventilator for less than a day. So the patients that had congestive heart failure and just needed some diuresis, patients that may have had drug overdose, or it may have been a delayed extubation surgery, that will take out about half your population. That's not a high-yield group to be doing this on because they tend to get off the vent and don't have a lot of the complications that we've talked about from sort of a longer ICU stay. The group that we focused on specifically were those patients that were on the ventilator for more than 24 hours and those who were on it for less than 2 weeks. More than 2 weeks, it becomes a chronic ventilator population. So again, your high-yield intervention period is greater than 1 day and then less than 14 days. So using that population as the denominator, we did set specific performance targets and assigned a point system in terms of the different goals that our system needed to hit. Next slide, please. Okay, now this work was actually funded by an HRQ R18 grant, and because of that, we actually had to set up quasi-experimental design. So HRQ was interested in looking at two things. One, there wasn't much data in terms of the bundle's actual effectiveness. Did it work? And then the other thing that HRQ was very interested in was the whole concept of implementation. So when resources are constrained, what are the most effective implementation techniques at a delivery system level? So to sort of test out those particular questions, we had two intervention groups. The first was our basic implementation program. So that basic implementation group had access to all the HR modifications and the standardized reports that we developed. But that was it. They did not have supplemental training, and we just sort of said, here's the EHR documentation. You guys, get moving on this and see what happens. Then our enhanced implementation group was the comparison arm. They had access to EHR modifications, standardized reports. They were involved more in depth and also at an earlier stage, in addition to having supplemental training related to the bundle. So those were the two groups. Our overall design characteristics, we had 3 hospitals in each group. We did match hospitals as closely as possible. The programs were operated concurrently. Obviously, sort of the cleanest study design would have been randomization. This is not the sort of thing that you can, because you're talking about sort of things that have to be implemented at a unit staff level, you can't really randomize at the patient level. And we did this within one healthcare system. You really can't randomize with the hospital level. So this quasi-experimental was the best study design to come up with. And then we looked at our outcomes via time series analyses. Next slide, please. Okay, so before we show the process uptake graph, just think back to a moment when I talked about the hierarchy of reliability. This type of graphic should look pretty familiar to your safety and quality improvement projects. These things tend to require multiple cycles. So if you think about that, where you're sort of in the state of nature, that would be the knowledge management cycle, where you can sort of get a process up to 40%, sort of above 50%. Just talking about something can help improve its performance. Then I think the steep part of the curve is where you have the hardwiring. That's where you go in, you change the workflow, you do the training. That's where your big delta is going to be in terms of process uptake. And I think moving it up to that next level and keeping it there has to do with accountability. So this graph, you probably have many examples of these within your own organizations. But I just thought it was interesting when you move to the next slide, because the graphics, I did not transpose graphics, but they look pretty similar. So what you have here is the adoption of the composite bundle over nearly a 3-year time period. So we started this project in July 2012, and the most recent data we have actually goes through April 2015. But you see, if you think about the 2 implementation groups, we had the basic sites, that is the line represented in blue, then you have the enhanced sites in red. You can see that at the start, we were in the 15 to 25% range. Where you see the steep part of the curve, that was where we had the active hardwiring. So January 2013 through October 2013. And importantly, that is where the EHR, the structured documentation, and the decision support went live. That was by far the steepest part of the curve. And then you can see that just with additional training, reporting, reinforcement, and accountability, we've had a steady climb upwards, so that the composite bundle is now being delivered almost 90% of the time. And you can also see that the uptake in terms of the basic sites and the enhanced sites, there was actually sort of a faster rate of adoption at the basic sites. So again, what that tells us is if you get the EHR workflow right, and you have the right infrastructure to do quality and safety work, this is something that many hospitals will be able to really succeed at without much guidance. So that was an encouraging finding for us. And again, just if you look at the middle part of the curve, we attribute that to better EHR and clinical workflow. Next slide, please. Okay, so process outcomes are good. Patient outcomes are better. And this table here summarizes our results and the odds ratios you see. So we actually noticed sort of a dose response effect of the bundle, which we also felt was encouraging. So our comparison group to these odds ratios is the group that had low composite bundle adherence, so below 50%. Then we looked at medium adherence to the bundle, 50 to 75%, and then a high adherence group, 75 to 100%. So we had over 2,500 patients in total, and that includes the low composite bundle group, so pretty decent sample size. And what we found was interesting. So if you look at the incidence of delirium, that actually went up the higher compliance you had with the bundle. And we don't think that the bundle is causing delirium. we think what's happening is sort of a twofold effect. One, if you're doing a better job waking patients up, you're going to have a lower rate of coma. We saw that. Patients who are not in coma, you're going to be unmasking more delirium. The other thing is that you have really trained your staff, part of in sort of doing a better assessment with the CAM ICU, so you're doing a better job of recognizing delirium. So again, this has been observed in some other studies looking at in similar areas. So what you may see sort of as an initial effect of higher bundle compliance is your delirium rate may actually go up. And I think that would be sort of a subsequent follow-up phase. That's one of the things we're working on. So we now know we're doing a better job of detecting it. How do we actually start to reduce that actual incidence of delirium? Likewise, you see sort of a similar trend with the duration of delirium. I mentioned coma. So coma, being deeply sedated, you had a lower risk of developing coma. And again, that risk was even lower if you had a higher bundle adherence. The duration of coma was shorter as your adherence went up with the bundle. Ventilator, there were fewer ventilator days, so 0.4 fewer ventilator days in the high adherence group versus the low adherence group. 2- and 4-fold more likely to be mobilized out of bed, according to your the category of bundle adherence. And then higher rates of discharge home. The other thing that we saw, and this was not necessarily expected, was that the mortality was much lower in the patients who had medium adherence and then high adherence groups. Of note, because I'm sure you're asking, okay, was this risk adjusted? The answer is yes. This was risk adjusted with Apache scores and as many things we could put into the model. So this is not just the fact that the patients are too sick so that they weren't getting these. We did account for severity of illness in the model. Obviously, because of the design of the study, I can't say that this is causal, that use of the bundle was the reason that the mortality rate was lower. But I would say it's an encouraging association. Looking at some independent data just in terms of mortality numbers related to our ICU care, we're seeing some similar trends. And the common denominator across our system has been better use of the ABCDE bundle. So to really sort of definitively prove that, you need a large randomized trial. But in terms of our thinking, this is good enough to sort of give us the signal that this is something we should be doing for our patients. Next slide. Okay, so the other question, costs. So we looked at a system level, the project team and these salaries were from the U.S. Department of Labor, so they're probably, they seem a little bit low to me, but it was the best we could find that we could sort of normalize across the U.S. And so you see the different portions of FTEs that we carved out to actually do this work. So physician and nurse champions, project manager, project lead, that would typically be a clinical person. Your data analyst is key, and then you're also going to need help from your information services team to do all the structured documentation that we talked about. So sort of the first year of deploying this, we would have an estimated cost of about $165,000. That actually goes down particularly once the EHR documentation is done and you've got sort of a durable training resource. You're really talking about something that moves down in $30,000 to $40,000 range per year, because at that point you're really talking about data management, reports, and then sort of any spot training or coaching that you would need to do. So in the overall scheme of things we do within our healthcare systems and the cost, this is something that would seem to be doable relative to some of the other expenses. And I know how many quality and safety mandates come down from on high, and they say we'll do it with existing staff. These numbers, I think in most cases, particularly after that first year, you could be able to maintain that sort of a normal operational budget without too much additional ask or having to sacrifice other areas.
Are there any questions from the group or comments?
Andy, this is Allison from Denver Health.
Hey, Allison.
Hi. I was just wondering what EHR you use.
So all scripts.
All scripts. Okay. Great. Thank you.
And for any Allscripts users out there, Allscripts actually, we've worked with them. They have created sort of one of their, I think they call them client connection modules. They're developing an ICU Delirium bundle, so a set of structured documentation, reports, et cetera, that would make it easier to adopt this. Okay, so some summary thoughts here. We hear a lot about sort of the foibles of health IT and how it isn't working. We really view this as a win for health IT, and that if you apply it in the right way, it can actually be a facilitator of best clinical practices rather than something that is seen as a barrier. The other thing that, and this is really, I can't emphasize this strongly enough. So in 2015, the common thing that we hear from our nursing staff and our physicians as well is that they spend way too much time doing documentation in the EHR. So that as we pitch this at a system level, one of the things we had to say is that this was going to represent an efficiency and a better workflow for your staff, and just bringing all that documentation together in one field rather than disparate fields. But doing that would be better for your staff and it would be better for your patients. And so I think this sort of emphasizes that in our current state, there's really a one-to-one relationship between EHR documentation, decision support, and clinical workflow. So your first step in this process, if you're going to pursue this, is to get with your IT teams and sort of understand the feasibility of changing the documentation and the decision support to be able to engage this. The other thing we found is that in this particular area, and this is probably true for a lot of things, those hospitals that have strong existing acumen in QI and safety, they were just able to adopt these and sort of get moving with the bundle without a whole lot of system-level support. So I think that's encouraging. For those who are in larger systems, there's variability in comfort levels across all of those. But if you have a good champion at a local level and they're comfortable with these types of things, you can get this bundle. They can get this bundle done very independently. Even with the health information management tools, this is still very much sort of a social phenomenon. I think that that's one of the advantages of hardwiring into the HR is that that's where the staff spends their time. So it just becomes something that it's day to day. This is what we do. This is what represents best care in our organization, that cultural change. And then likewise, the clear lines of accountability in terms of making this a system level goal. That was crucial in sort of getting our leadership to buy into this as well. And then the last thing is just in terms of what is your most effective implementation sequence. I would say that based on our experience in this, your first step would be to get in line in the ISQ. I know most modifications in organizations that are going to be busy, you're looking at a 6 to 9 month wait. And so work with your patient safety officer, work with your chief medical information officer, chief nursing officer, that this would be a high yield type of thing to put in relative to some of the other requests that may be on the list. And what I would say is get that request in, get the documentation built, then train your staff to the EHR modifications. We sort of, knowing what I know now, we could have shaved probably about 4 to 6 months off of our adoption process, and we could have saved another cycle of training. So what we initially did, we did a cycle of training, then the EHR documentation came out, then we had to retrain people. So I know we're all dealing with limited resources. EHR modifications first, then train to that would be my particular suggestion. Okay, next slide. All right, so just in terms of some specific metrics that we might look at for the HVAC safety program, so your structural metric would be, does your hospital, does your system have a systematic ICU Delirium screening and management program in place? That's a simple yes or no. Process metrics, I defined the patient eligibility. So again, you're looking for patients on the vent greater than 24 hours but less than 14 days. If you could collect this by hand potentially. If you did that, if you didn't have the electronically derived reporting, I would say look at 20 patients to get a decent sample size from each unit. And then you could see the percentage of patients who met the appropriate sedation scale, what percentage of them were screened with the CAM ICU. It's generally recommended that the CAM ICU is done twice daily. Typically, nurses will document it and do it around shift change, just as part of their tasks at those times. And then last, there are several outcomes we can potentially look at. So one would be the number of patients with at least one positive CAM or CAM ICU during their stay. So that's really the delirium prevalence within a unit. Incidence would be the new cases of delirium that were developed during their ICU stay. And again, we're defining this as one positive CAM ICU. When the CAM ICU is negative for 2 consecutive measurements, that's when the patient has cleared their delirium. Other things you can look at, average number of days with delirium or coma. So, again, in the case of delirium, that's the number of days that they had a positive CAM ICU. And then lastly, other things you might want to look at would be length of stay in the ICU, time on the ventilator, disposition to home versus skilled nursing facilities. One thing I would caution, if we're going to look at an association of the bundle with ICU length of stay, exclude those patients who died. This is sort of a common issue in critical care trials, is that you don't want to give, if you eliminate the patients who die, they actually have, they shorten the average length of stay in that group. So make sure you exclude those if you look at the impact of bundle compliance to length of stay. And that's it, Jason. Next slide is just for discussion and questions.
Excellent. Thank you, Dr. Massica. That was great, and a lot of good information there. Again, we'll open it up to the group for questions. Just a reminder, if you did put your phone on hold, just unmute it, and we'll open the line up.
Hi, this is Allison Sable again, Andy. Is there a time frame? I know you showed some timelines for how you did this improvement initiative, but is there any sort of time frame for HVAC safety program?
Yeah, so I know we're going to, now one of the things that's been brought up, and I need to talk with Jason and Lucy, is that we can make, I have one of our critical care nurse champions, she is willing to conduct sort of a CAM ICU training session at the Salt Lake City meeting. We can make arrangements for that. So that'd be one option in terms of actually getting this up and running. There's obviously defining metrics and how I think the timeline for individual organizations is going to depend on where you're at in terms of the structured documentation. Obviously, EPIC's a popular EHR. I don't know that they have an ABCDE Bundle module yet. I've heard that they're working on it, and the Allscripts one is still under production, and I can't speak to Cerner or some of the other systems. So this is something you can do it. I mean, you can start screening for delirium. That would really just be a matter of training your staff, and then sort of really doing the full scale approach, I think, is something you have to plan for with your IT groups. But I would say overall, Allison, if you started thinking about it today, you would have been very successful and efficient if you could have everything up and running in about 9 to 12 months.
So I guess my follow-up is that okay from the HVAC or the HIN safety, whoever is in charge of this program? Is that the timeline? Is that the timeline we're talking about, or are we looking at one of our fast-moving projects for this?
Well, if you looked at the proposed metrics that I was talking about, Jason, if you go one slide back, those are things that can be collected on paper. What I'm talking about, what takes a year to get to, is when you have those sort of those automated reports and all the things that I was able to generate out of our EHR. These are things right here. You can do those with a small sample of patients just based on paper. That's 3 months.
Allison, did that answer your question?
Yeah, that did. I guess, I mean, I'm sure we'll hear more about this program and sort of what you're, I know we're looking at ABCD, but, what you're asking each site to do to submit, the time frame.
Yeah, and again, I think if, probably what would be appropriate within the time frame for the for HVAC safety would just be, do you have a systematic delirium screening management program in place? Like, just, do you even do the CAM ICU? So I think if you had sites adopting the CAM ICU, doing it reliably, and starting to generate some data just in terms of where they were at, that would be, I think, sort of a successful project and a good starting point that everyone could do regardless of your EHR state.
Right, and Allison, I think maybe one point of clarification is this is essentially viewed as a member-initiated HVAC project. So this is you essentially your individual site would be, I guess, it voluntarily signing up to implement this process. The way the HVAC safety program is structured is just to focus on the specific areas, and then our subject matter experts like Dr. Masika lay out some of the best practices that are possible to help in working in those areas. But this isn't an HVAC, I guess, decree in a way saying, this is something you have to do.
Right.
And Allison, Denver Health may actually be, you may be further ahead in this than you think. I was actually a co-investigator with Ivor on a trial where they were using the ABCDE Bundle. So there may be more elements of this than you might think initially, already in place.
Right, yeah, I just didn't know for sites, if you had, I know at one point you had asked for people to start, pulling just some pilot data to look at, but I didn't know if there was, with the program, like a timeline, like you're asking, your question structural. Do you have a systematic ICU delirium screening management program? And I'll answer that, might take a couple days, but you can answer that. But then for us to say, can we, look at pulling some data electronically, or at least the 20 patients, is there, are we trying to get something for Salt Lake City to have a discussion there, or is this?
So that's, and I guess we didn't have time for the intro, so that we're kind of refiguring the one of the CNOs who had been leading the Delirium group. We're kind of refitting this within the framework of the HVAC safety program, and that just happened within the past couple of weeks. So I think there's still some transitional work. I would say yes. The deliverables and the specific focus, I think there will be much more clarification on that in Salt Lake City, and hopefully even before then. So.
Okay.
Yes, that's correct, Andy. Thank you. Any other questions or comments? All right. So it looks like we may be ending a couple minutes early. So I want to thank Dr. Masika again for presenting this, and I want to thank everybody for joining. As kind of alluded to in the comments and conversation, the safety program is fairly new in getting going. It's part of it's a continuation of the existing hospital engagement network that had been in place for 3 years, and we are in the process of getting the work started again under this new safety program structure. So I hope that a lot of people are planning to attend the in-person meeting in October, which is when not only kind of the safety program is really going to be hitting its stride, but I think also HVAC is going to be officially launched as HVAC 2.0. So I think a lot of new information and changes will be presented at that meeting, and in line with the safety program. There are 2 sessions where the safety program will be essentially breakout sessions during the meeting.
Jason?
Yes.
On that topic, the delirium stuff is amazing. But have announcements gone out for that October meeting and I just missed it, or how have they gone out?
So the HVAC program office takes care of that.
Oh, okay.
I'm sorry, who is that talking?
Oh, I'm sorry. I didn't tell you. It's Jean Bigelow from Urban Central Region.
Oh, okay, Jean.
Near Mountain.
Yeah, Jean, I'll go forward the registration information. The meeting's in Salt Lake City.
Okay.
So I'll forward it to you, and you can register. And anybody else, either contact the program office if they haven't seen the announcement. They just sent the registration link earlier this week. So either contact me or the HVAC program office to get that information. But, Jean, I will follow up specifically with you with that information.
Thanks, Jason.
You're welcome. Any other questions or comments? Okay, well, thanks again, everybody, and we'll be in touch soon and hope to see many of you at the meeting in October. Have a good day.